apparently, and I'm going from what John Crutzen said in the Chicago Tribune, that the Swedes have agreed to open up their studies to audit and to analysis from other international people, including the NCI. And this was apparently due to the controversy that has been going on in this country. They wanted to settle that controversy by doing what people have been asking them to do for many years. And I'm concerned that they follow through on that, and I hope that these proceedings and others don't slow down that impetus.
Well, what would it be about the NCI guidelines that would lead them to withdraw the offer?
Well, there may be no more reason to open it up. I mean, if there were...
the fact that the NCI reiterated their guidelines?
Yes.
Okay, it's not something in addition to that?
No,
Okay.
no, just less uncertainty in this country.
Thank you, Dr. Berry.
Can I just make one comment about something Dr. Iyer said, or is that out of order?
No, as I said, it's a comment, but remember, we're not a debate.
Oh, okay, it's an occupational hazard that I have, that I complain about people that look at particular aspects of data that make a point that they want to make and ignore other aspects. Dr. Iyer pointed to the Cornell study that addressed the Malmo trial and points out that if you look between years 8 and 11, you get a benefit for screening. What they don't point out is if you look between years 3 and 6, you get a negative benefit for screening. In fact, the increase in mortality between those years was 58%, 30 deaths versus 19 deaths. That study was really very flawed, much more flawed than any of the trials that we're talking about.
Dr. Berry, could I ask you, there, as far as I'm aware, only 2 widely utilized other forms of screening, either self-exam or clinical physician screening. Is that right?
That's as far as I know, yes.
Right, and so, I mean, this is a crapshoot, right? I mean, as part of what we're trying to figure out here is a lot of women either can't or won't do self-exams, don't know what they find if they do them, and a lot of doctors may or may not have the same, clinical judgment that their neighbor down the hall might have. So, I mean, in each of these instances with respect to screening, we're comparing, it seems to me, imperfect methods across the board. Yeah, and, so, I mean, part of what we're attempting to do, and I think Dr. Frist's, Senator Frist's, questions certainly got to this point, it's a very little benefit for most of us lay people who are on the receiving end of conflicting advice, to hear the difference between 1 and 3 and 5 and 8 and the rest of it, when we have to make a judgment. And based on the best available information, and even based on many of the most unequivocal statements in your own written testimony, we put our odds with going ahead and having mammography, knowing, as we know, that it's not the perfect answer. It's like getting your teeth x-rayed. Maybe the carie they find would never turn into something that you either had to have filled or have a tooth pulled, but, you do the best you can with what information you've got. So,
thank you, Senator Clinton.
To introduce Dr. Carolyn Runowitz, who is the Vice Chairman of the Department of Obstetrics and Gynecology at St. Luke's Roosevelt Hospital in New York. She faces the dilemma of what to tell her patients about mammography every single day, in fact, many times a day. And she's speaking on behalf of the American College of Obstetrics and Gynecology, and I'm delighted that she could be here with us on this panel.
We turn to Dr. LaSalle Gaffal, also, who's the chairman-elect of the Susan B. Komen Breast Cancer Foundation. He comes to us as the chairman of the Department of Surgery at Howard University, a position he's held for more than 25 years, and he's going to serve 1 year as the chairman of the Komen Foundation, which, of course, has been one of the leading advocacy groups, well known for its Race for the Cure, but for not only raising money, but also raising consciousness.
Good afternoon, Madam Chair and distinguished members of the subcommittee. I appreciate your invitation to testify today on behalf of the American College of Obstetricians and Gynecologists, or as it's better known, ACOG. ACOG continues to recommend mammography screening every 1 to 2 years for women in their 40s and annual mammograms beginning at age 50. We are here today because of publicity surrounding a study done by Danish researchers recently published in The Lancet. The Lancet study questions one of the most widely held beliefs in preventive medicine, that screening healthy people for cancer and detecting it early saves lives. It is important to note that this is not a new study, but a reanalysis of already existing published data. Scientific debate on critical issues like this one is common. ACOG supports periodic, evidence-based, peer-reviewed analysis of all available data on mammography, including a review of studies like the one in Lancet. We take its criticism of prior mammography research very seriously, and we want to make sure that the Lancet study itself stands up to rigorous review. In fact, the Preventive Services Task Force announced last week a different conclusion than that of the Lancet study. Their review of the data found that breast cancer death among women randomized to screening in 7 trials that included women older than 50 showed a 23% reduction in mortality. And contrary to prior testimony that you have heard today, in 1993, an independent analysis of the actual data from the 5 Swedish trials cited in the Lancet study showed a statistically significant 24% reduction in breast cancer mortality in the screened group. With such conflicting data, where do we go from here? Initially, I think all of us, members of Congress, doctors, patients, journalists, researchers, need to understand the difference between the very rigorous standards that scientific evidence must meet to clearly prove the worth of a test and the practicalities of what must be done in physician's office when conclusive scientific evidence, 1, is not yet available, or 2, may never be available. I make this second point because at this time and in the future, there would be clear ethical and moral problems in performing a randomized prospective clinical trial in breast cancer screening that medical scientists say are the highest quality of scientific proof. I ask you, how many women today would be willing to go without breast cancer screening in a clinical trial to prove or disprove a statistical point? We may have to live with a certain amount of uncertainty when it comes to the results of mammographic screening trials. I also think we need to educate our patients about the facts behind the recent media hype, and that's what this is all about, media hype. While the Lancet study has raised several important issues, as a practicing physician, I have to look at this through the eyes of individual patients. I explain to patients that this debate has nothing to do with the effectiveness of breast cancer treatment. There is agreement that treatment saves lives. Instead, the debate is whether earlier treatment made possible by the early detection of tumors is better than later treatment. I tell them that early treatment made possible by early detection does make a difference. I explain why I think the accumulation of research trial evidence over the years has strengthened the science behind breast cancer screening, and that the data in aggregate demonstrate improved health outcomes with benefits outweighing the harmful effects. I discuss the recent controversy and my own recommendations. I explained that scientific debate on critical issues is common, but well-established guidelines should be followed unless there is compelling evidence to alter or abandon them. The news stories have already had a large impact on patients. They are confused, and they express a loss of faith and confidence in mammography. Some even misinterpret the media coverage and take away the message that mammography is bad and even causes cancer. Over the years, we have made significant strides in educating women about mammography by breaking down financial, physical, and psychological barriers to women seeking mammographic screening. I fear, as does ACOG, that these barriers might be reinforced by this negative attention and uncertainty generated by the media hype. As already mentioned by Senator Murkowski, I and ACOG are also deeply concerned that the ongoing controversy might discourage health insurance plans from covering this important screening tool. As frustrating as this controversy may be to the women suffering from breast cancer, the silver lining is that it brings to light a goal that we all share: the need to be even more vigilant in supporting research efforts to enhance not just early detection, but treatment as well as prevention and finding a cure for breast cancer. Until then, mammography remains as one of a number of strategies that can help save or improve lives. Even if the screening tests we have now are not as good or as conclusive as we would like, they are the best we have at the moment. As a practicing physician, I would be derelict in my duties